Sorry.
Welcome. This is George Thibault, President of the Macy Foundation, and we're very pleased with the interest in this report, which is currently available online and soon will be available in print form as well. I don't think I need to tell any of you how important graduate medical education is. It is where 120,000 residents yearly in the United States are imprinted as they make the transition from medical school to independent practice. Residency training in the United States has been a model for the rest of the world. But like all other aspects of health professions education, it needs to adapt to changes in our delivery system, changes in disease burden, and changes in the demography of our patients served. Because GME is primarily funded with federal dollars, there's been a sense that changes that are necessary would require national movement or federal action. The Macy Foundation has hosted two previous conferences on topics of GME reform, looking at issues of governance and finance and looking at issues of content and structure of GME programs and making a number of recommendations. These conference reports were the basis of an Institute of Medicine report, which produced a very thorough and extensive study of the current state of GME and made a number of recommendations for changes. In spite of these excellent conference reports, there has not been much movement for national reform because the issue is very complicated, involved in politics and financing. At the same time, important innovations are going on around the country, and we knew that from our travels, that places are innovating to meet local needs. And we felt that if we could describe, encourage, and disseminate these regional changes, that these would help to promote more national innovation as well. So we embarked on a plan to co-sponsor 6 regional conferences with academic medical centers around the country. And we had outstanding partners in this. First, Vanderbilt University Medical Center representing the Southeast, and Don Brady, who you will hear from. The UT system, represented by MD Anderson, and representing the Southwest United States, and Diane Bodurka chaired that conference. The University of California at San Francisco represented California, and Bobby Barron chaired that conference. The University of Washington School of Medicine and the WWAMI program represented the Northwest, and you'll hear from Suzanne Allen, who chaired that conference. And Partners Healthcare, represented by Deborah Weinstein, who you'll hear from, represented the Northeast. And finally, a Midwest conference sponsored at the University of Michigan Medical School, chaired by Joe Kolars. Each of these conferences were given a large amount of latitude in planning their conference so that it represented their sense of what was needed locally and highlight the innovations that were going on in their region. So the format of each conference, the topics selected for discussion, were determined by the conferees, by the chairs and their planning committees. In spite of these differences in format, some very common themes developed across the 6 conferences. First, we can say all of the conferences were incredibly enthusiastic. The leaders of GME had a hunger to get together, to share their work, and also to validate the importance of the work they were doing in GME. Besides this general enthusiasm and a sense to keep this conversation going, 6 themes that really begin to define what we think will be the future of GME programs emerge from all of the conferences. The first is that GME programs and program directors need to be more outward-looking. As a former program director myself, I know how consumed one can be with the inward-looking issues of schedules, work hours, and meeting institutional needs, which are very important. But there was a clear call in all of these conferences that we should think of GME not in an inward way, but in an outward way, how GME can contribute to improving the health of the public and improving the issues of health disparities and other regional issues. Secondly, that residents can and must be empowered to improve quality and the value of care. Residents should not be seen as a problem, but should be seen as a solution. We have an incredibly talented workforce in our residency groups, and we should be using them more to address institutional issues and broader societal issues about quality of care and value of care. And we saw many examples of that. Third is that residency program and sponsoring institutions will need new partners to adequately train residents. This means more community outreach, establishing other training sites, and sometimes helping others create new sites and new programs so that the programs and the sites of training will be more representative of the patients served and the sites of care of the future. The fourth important theme is that residency training is becoming more individualized. And I would say that individualization occurs in three ways. One is the identification of more tracks to train residents for specific career pathways so that not all residents will do the same things. Residents being prepared for rural careers are different than those being prepared for urban careers, as one example. The second form of individualization is more individualized feedback so that the resident performance is monitored with real-time feedback, and rotations may be altered, content may be altered to deal with individual resident needs as residents progress with different paces through the residency program. The third form of individualization has to deal with a healthy increased emphasis on wellness of residents and identifying things within programs that will create a greater sense of balance and resilience for our residents, and will deal with individual problems and needs as they arise. A fourth theme is an increasing focus on teamwork training and interprofessional collaboration. We know that all of us in our career will work in teams, but heretofore our residency programs, again, have been more inward-looking about the needs of their own service, their own profession, their own discipline. Residency programs of the future will need to look more across the disciplines of medicine and have co-training opportunities for that. And even more important, will look more across interprofessional boundaries to have co-training and co-educational experiences with other health professions such as nursing and pharmacy. And finally, a very important message that came from all of the conferences is that GME funding is becoming more diversified. And while Medicare funding remains still the principal source of funding, there are more and more examples of state funding, both through Medicaid programs and through line appropriation at the state level, with funding from health centers and health systems themselves, and also with sometimes community consortia that have developed to fund new GME programs. So with this, I want to turn it over to 3 of the 6 co-chairs to give you a flavor for how each conference was constructed and some of the highlights of innovations from each conference, and then we'll come back at the end for some summary remarks. So Don Brady from Vanderbilt University in Nashville chaired our first conference, and he is now going to take over.
Hello, this is Donald. Can everyone hear me now? I will assume so. So the conference in Nashville at Vanderbilt was labeled GME as an instrument of change to improve the health assistance populations in society. I was very grateful to have the planning committee help of people representing 6 different disciplines as well as 4 different states across the Southeast region. As we move to the next slide, you can see who we assembled from across the region, and we actually had every state in the Southeast represented. and also several what I labeled as friends, people representing HRSA, the CDC, ACGME, and Veterans Affairs. And why did we assemble? One of the major driving forces for us getting together was that we recognized that the health statistics of the states in the South in particular usually rank in the bottom quintile of the United States. And we really have an opportunity to change and improve the health of the population both at the individual as well as the community, state, and regional levels. The next slide will give you an idea of the different people that we brought together. We really felt it was important to bring together people that represent every aspect of the training of a physician, not just the MDs, the DIOs and program directors and the residents themselves, but also to bring together patient advocates. We had the president of the National Patient Advocacy Foundation here, public health officials at the local, regional, and state levels, including the president of the National Association of City and County Health Officials. We had people representing the federal government, the VA Office of Academic Affiliations. We had CMOs, CNOs, CEOs, as well as deans of medical schools. Several state hospital associations brought representatives to the meeting, department chairs, and then as well we had 2 people representing ACGME, 2 from the VA, and our friends from the Macy Foundation, who we are grateful for sponsoring the meeting. The theme of our meeting really centered around systems, populations, and society. And we brought people together for 2 major reasons. One was to work collaboratively in a design shop space at Vanderbilt to think about what are the barriers to innovation that cause us not to be able to be as creative as we might be, and as Dr. Thibault mentioned earlier, the outward-facing look of how graduate medical education can help transform health and health care. So we really centered around the 3 themes of systems, populations, and society. The systems really centered around the use of reflective data to improve performance. And the theme that you see there in bold, the example in bold where it says Vanderbilt Anesthesiology Quiz Time, was one that I would like to speak a little bit more about. This is an effort within our own medical center, within the anesthesia department initially, but now anesthesia, cardiology, and radiology, where we look at the practice patterns of the physicians as well as the schedules in anesthesiology for the next day's operations. And based on what the physicians are about to see, we push questions out, quick, 1 question, multiple choice, to their cell phones that they can answer during the day based on the cases they're about to see to test their knowledge of those cases. We can then use that data to see how well the physicians, both the residents, the fellows, and the faculty, do on that question to help us gain an understanding of how well they know the cases they are managing. And therefore we can then build more questions and or build more systems to help improve the patient care out of having better knowledge among our providers. A future goal is that we will actually use the practice data of individuals as well as divisions and departments to tailor questions not just on what's coming, but on the data of the patients they've actually already seen. In populations, our theme was really around reducing health care disparities, and we had 2 presentations there that represented that. I would speak to the Florida International presentation, where their family medicine program in South Miami literally embeds residents in a federally qualified health center, which sponsors the residency program, and teaches them about social determinants of health as they are engaging in their practice. The residents go to homes, they longitudinally follow people in their homes, and as they are providing clinical care, they're also learning the social determinants of health and doing service learning, engaging with law, education, public health, outreach organizations, nursing, social work, and others to affect the social determinants of health while they're affecting the individual's health themselves. They're scaling that model across the Miami area, and is a really, really innovative model to try to reduce health care disparities, particularly in the Hispanic community, but across many communities in South Florida. Our final area, which I won't take the time to speak to individual examples today, but I'm happy to if we have any questions and answers, was around innovative funding models which are occurring in the state of Georgia and the state of Florida, and as we learned at the conference, also now coming up in the state of Mississippi. As for next steps from our presentation, we actually had at the end of our day together, we had people sign a commitment card of something they would do innovative in the next 6 months. We then, just last month, returned those cards back to them to find out where they are in their innovation, how far they've been able to progress, and then we'll be bringing people back together again this coming February for a second regional conference using the same themes, presenting more about the advancements the individual participants were able to achieve over the last year, as well as continuing to collaboratively work together to build partnerships, to develop relationships, and move forward in improving the health of individuals as well as communities and the region. So I'm grateful to the Macy Foundation for what we were able to do and look forward to our next conference. And I think at this point I'll be turning it over to Dr. Allen to talk about the WWAMI Summit.
Great. Thanks very much, Dr. Brady. This is Suzanne Allen. I'm the Vice Dean for Academic, Rural, and Regional Affairs for the University of Washington School of Medicine. In that role, I'm responsible for what we do across our 5-state WWAMI region, which stands for Washington, Wyoming, Alaska, Montana, and Idaho. We cover about 27% of the land mass of the United States and only have about 4% or so of the population of the United States. So as we move to the next slide, we were very pleased to work with the Macy Foundation as we planned our 4th GME Summit that we have held. The other summits have largely been focused on how do we expand graduate medical education in the Pacific Northwest. With the help of the Macy Foundation, we were able to also focus a little bit more on innovation. We did have the same planning committee that we've had previously with our other GME summits to plan this one. We invited people from the WWAMI region as we have in the past, as well as from Oregon, Nevada, Utah, North Dakota, and South Dakota. We did have individuals from across the WWAMI region, as well as Oregon and Nevada, who joined us, as well as representatives from the ACGME and the Macy Foundation, who did distribute us a little bit further towards the east across the United States. As in past summits, we had great representation from a variety of different individuals and different types of communities and different types of clinical entities who really make it possible as we look at how do we continue to expand and to innovate when it comes to graduate medical education in the Northwest. As we go into the next slide, one of the areas we focused on was expansion of residency programs. We know that we have some unique physician workforce requirements because of the rural and frontier nature of the Northwest, which makes it frequently difficult to have access to health care for many of the citizens who live in our region. Some of the things we really tried to focus on, if you're looking to create a new program or looking to expand, we really talk about the things that you need in order to be able to do that. One is making sure that you have leadership support for creating something new or expansion of a current program, making sure that you have a physician champion who will help you in that endeavor, making sure that you have the clinical resources to meet accreditation standards, and then, of course, making sure that you have the funding required to either create a new program or expand a program you currently have. We did spend some time talking about funding, as Dr. Brady mentioned. Different areas are really looking at creative ways to provide funding. We're very fortunate in the Northwest that our states are very supportive as far as providing funds for us to be able to continue the GME that we're doing and look at new ways to fund expansion or new programs. As we move into the next slide to talk a little bit more about innovation, the innovation I really want to focus on is how are we working on that physician workforce for our rural and underserved areas. And I want to talk just briefly about two things. So one are training tracks, and the other one is community collaboration, and these really go hand in hand. I want to focus on two different areas for training tracks. One is pediatrics, and one is psychiatry. We've been fortunate in the Northwest to have a psychiatry training track as part of the Department of Psychiatry at the University of Washington since 1991. Originally, we had that training track in Spokane, where residents spend their first 2 years in the Seattle area and their last 2 years in the Spokane area. That particular training track kept over 50% of its graduates within a 100-mile radius of where they trained in Spokane. And that training track has since graduated to become a full 4-year psychiatry residency program in Eastern Washington. At the same time as that program was winding down, we created another psychiatry training track in Idaho, where again the residents spend their first 2 years in Seattle, their last 2 years in Idaho. That program thus far, it started in 2006, has kept over 60% of the graduates practicing in the state of Idaho, which again we consider a great success. That program does have ACGME full approval for the training that it provides, and has been very attractive to people interested in going into psychiatry, either in Eastern Washington or Idaho, that allows them to finish their training where they may eventually want to practice. Talking a little bit more about pediatrics in a training track, we have a new program called the Alaska Pediatric Residency Training Track. This program allows residents to finish 4 months in each of their 3 years of pediatric residency training up in the state of Alaska. We worked very closely so that residents have 2 different communities that they will work with across that 3-year training in the state of Alaska. So one community will be located in Anchorage, and the other community is located in either Bethel or Fairbanks. For students or residents who spend their time in Fairbanks, they then are at a tribal location in Anchorage. And for the residents who spend time in Bethel, which is a tribal location, they are at a private practice in Anchorage for their training. This particular program did require permission from the ACGME, as the program does not meet the specific continuity requirements in the pediatric standards. However, residents are getting good continuity during the time they are spending in Alaska. This particular program really spent a lot of time working with the pediatric communities in Anchorage, physician communities in Anchorage, but also the community at large in Bethel as well as in Fairbanks. So far, the program has 2 years of graduates. Each year has 4 residents. And all of those graduates have practiced now at some point in time in Anchorage. The 3rd class coming up looks like we'll probably have 3 of the 4 practicing somewhere in Alaska. So from the standpoint of really meeting the needs of the community by creating more pediatricians, the communities thus far feel like this has been a success, as Bethel, Fairbanks, and Anchorage have all benefited from the graduates of this particular program. We are in the process of planning our next GME Summit, which will likely be sometime next fall. And we're very excited to continue to work on this as we look to expand and innovate with GME in the Northwest. So now I'm going to turn this over to Dr. Weinstein, who was in charge of the Northeast Conference.
Hi, thank you very much. This is Deb Weinstein. I'm the Vice President for Graduate Medical Education at the Partners Healthcare System in Boston, and it was an honor to host the Northeast Conference. At our gathering on May 6th, we had about 90 participants who spanned a bunch of different roles. The majority of folks were GME program directors and DIOs, but we also had some faculty at large, both from medicine and the health professions, some students and trainees, and representation of deans and CEOs and CMOs. These folks came from 28 different teaching institutions in 7 states, and we also had a number of representatives from key national organizations, including ACGME, AAMC, Bob Jesse from the National VA, and folks from the Macy Foundation. We go on to the next slide. Then it gives you a glimpse of our agenda. We were thrilled to have Don Berwick give the keynote address. I think many people are familiar with Don's work as an innovator in healthcare delivery. So he was an ideal person to talk about innovation in GME. He made a strong case both for why GME innovation is imperative in the context of healthcare delivery transformation and how it's also possible in this same context. We then spent a lot of the day on hearing brief presentations from 12 different presenters who were selected from among almost 50 submissions by the selection committee. We had 9 participants on the selection committee from 4 or 5 different states, all folks with lots of GME experience, and they selected the presentations based on merit rather than any upfront decision to highlight different themes. We just wanted to see what was out there and what seemed exciting. But it turned out that the selected innovations did cluster around 3 themes. One of them was actually not within these themes and reflects, I think, what others were talking about more, the idea of growing your own providers. But other than that one, the presentations clustered under the themes of professional development of residents, interprofessional education and practice, and curriculum development. And then we also spent some time in the afternoon talking about the obstacles and the enablers to innovation and how we might more effectively disseminate innovation in GME. We go on to the next slide. It shows you a number of the innovations that were presented. And in fact, the 4 that are shown here are the ones that the audience members thought were the most applicable to their program. And we had an audience response system so that we could ask in real time for reactions to the various presentations. So the 4 that were thought most applicable included one curriculum initiative that involved a number of institutions working together to create a core curriculum that was focused on active learning and incorporated principles of adult learning, and it was it seemed like an excellent experience both to create it and to make it available, and it's now in wide use. Another was reaching their personal best. It was about a professional development coaching program that was started at the MGH that I'll tell you more about in a moment. And we also heard about an iPhone app that's called Simple for short. It's a system for improving and measuring procedural learning and gets at the need that I think many programs face in terms of how to more efficiently and consistently get evaluations and feedback on resident performance. This one focuses on surgical procedures initially, but it's now being generalized to other settings. And then the last one that was thought to be most applicable was a core curriculum in patient safety and quality improvement, which is also being implemented at the MGH. The same curriculum across all specialties with some specialty-specific examples, and then follow up what we call spaced education through a program called QStream to assess and document learning. Moving on to the next slide, I'll give you a little bit more of a flavor about the MGH Coaching program, which seems to be catching on quite quickly in that at least 10 other institutions are in the midst of implementing this program. MGH now has 94 coaches that are trained. These are just faculty in the Department of Medicine who stepped up and said that they were interested in working with residents in this way. The training is very brief, just 2 hours a year, and having now done this for a few years, they're finding that the vast majority of coaches are enjoying it and want to stay as part of the program. There is a certain stereotyped curriculum that has been designed and is implemented so that there's a consistency in terms of what's offered at different stages of the 3-year residency. But then there are also some common elements as shown here that are part of every coaching meeting. The person who developed this, Carrie Palomara, has been active in going out to other institutions and helping to train the trainers as an example of, I think, effective dissemination of this innovation. And for anyone who's interested in more detail, there's a publication in Journal of JGME, Journal of Graduate Medical Education, from December 2015 that outlines the early experience of this program. And then moving on to our last slide, I just wanted to give a few examples of what the folks in small breakout group discussions highlighted as enablers of innovation. We asked them to talk about both the obstacles and the enablers. And interestingly, the first thing on this list as an enabler was also on the list as an obstacle. That things are changing so quickly in healthcare. You know, some felt, how can we possibly focus on GME? How can we know what healthcare system we're designing GME to serve? But then many people felt that that's the only way we are going to get effective reform, is to harness all of the energy and perhaps even the chaos around this rapid evolution of healthcare and design the new GME system in that context. Others pointed out that if we identify analogies outside of medicine, such as examples from business that are new innovations that are being disseminated effectively and quickly, and people are accepting the change, that will help us in medicine to do the same. Others pointed out that the alignment with institutional priorities is important at each one hospital or healthcare system in helping to get the majority of people to accept an innovation in GME, because GME isn't often seen as the primary priority of those institutions. Having an influential champion was noted as an important element, and communicating success stories, because if we can do it in one area, we can do it in another. We also talked about how a number of the medical education journals and the healthcare journals overall have new opportunities to publish innovations, specific features that are geared toward this. And the article I just mentioned in JGME is an example of this. Academic Medicine and many other journals also have this, so we should take advantage of it. And then in the end, I think the consensus was that careful preparation, careful planning, and a lot of persistence is important to getting these innovations off the ground. Thank you. I think we're going to go back to
thank you, Deb. I think that last slide was a wonderful summary of the work that all of us have ahead of us. So I want to just summarize briefly by saying these 6 conferences exceeded our expectation for both the exciting and innovative ideas we heard and also the enthusiasm of the participants. Overall, we had over 800 participants that represented 39 states and the District of Columbia. So these are not isolated examples at all. The enthusiasm and creativity of the people leading our GME programs is something we should all be proud of. And I think in these innovations we can begin to see the shape of the programs of the future that are in fact responding to the changing delivery system, changing societal needs, and changing demographics of our patient population. So we left these meetings feeling very optimistic about the future, but realized there's still a lot of work to be done to encourage and support these innovations. It takes the creativity of the program directors, but also takes support from the top of the institutions, flexibility, and willingness sometimes to take risk and chances. But we are very heartened by that, and we hope that this will continue this movement across the country so we can further champion the innovations that will further align the important graduate medical education programs with the changing needs of our society. So we're going to open it up now for questions. We have about 20 minutes left, and we will try to field the questions. I'll try to triage them and distribute them. And If we don't get through them all, we'll certainly invite you to submit them, and we'll try to post the answers.
Okay, our first question. What kinds of educational models do you see presenting the biggest opportunities for GME innovation?
Well, I'll ask the others to chime in. I don't think there's a single model. Flexibility is going to be called for. I really do think that the educational programs of the future are going to be much more individualized, both to the individual needs of the trainee as well as to the site-specific situation, both for where the opportunities for learning are and what the local needs are to be addressed. So I think rather than a single model, we should be thinking about a diversification of models. And there'll be many different ways to achieve the goal of fully trained physicians. But let me ask if there's any comments from my other three chairs on that.
Sure, this is Deb. I would just add to what George said by citing competency-based education as an example of individualization on a large scale. If we put that into practice more broadly, it could turn out physicians more quickly, potentially, and if it doesn't, it could certainly turn out physicians with a higher level of competence. As people know, this was tried in Toronto in orthopedics, and there's currently a trial in the U.S. in a handful of institutions in pediatrics. So I'm anxious to see how that progresses.
And this is Donald. I would agree. I think there's so many different education models that are possible, and the innovations are occurring within the current models as well as models that are evolving. They're occurring in the primary care disciplines in psychiatry, family medicine, internal medicine, pediatrics, but they're also occurring in the subspecialties. And I think our conference, we saw the blending of the subspecialists with the primary care presenters to understand the need for both. And so I don't think there's one model where innovation is actually occurring the most.
So, one other comment I'll make on that, and then we should move on to the next question, that the ACGME had representatives at all of our meetings and made it clear they were there not to as regulators but to learn. And I think the current environment there is very open and very supportive to innovations. Now, standards are still going to have to be met. The innovations are going to have to prove that they are not compromising in any way those standards. But I think there is a moment in time of greater flexibility in the models. Secondly, the VA was at every meeting. And the VA has been a wonderful laboratory, continues to be a wonderful laboratory for innovation. It's particularly done interprofessional education and innovating in primary care education that I think are models for the rest of us. So let's go on to the next question.
Okay. Can the presenters talk about the challenges and recommendations for effectively evaluating the outcomes of the educational innovations?
Well, this is, of course, an important area throughout all of education. We need more emphasis on evaluative tools. We need more support for research in educational outcomes, which has been underemphasized certainly in federal funding for research. And an earlier Macy conference called for a National Institute for Interprofessional Education to do just that. That hasn't happened, and it probably won't happen in the foreseeable future. But we do feel that we should be evaluating, of course, all these innovations, evaluations both at the individual learner level, but also evaluation at the program level. Both are important and require different approaches and different methodologies. So see if others want to chime in on that question.
Well, I think it links, this is Deb Weinstein again, I think it links to the need we have for more consistent data collection in GME so that we have the opportunity to do research at scale. And the National Academy of Science, Engineering, and Medicine is going to host a workshop next year looking at GME outcomes and metrics. So hopefully that will be the beginning of more consistent data collection that will help to do this kind of work that you're mentioning.
So another question?
Okay. Deb, this question is for you. We'd like to know more about the coaching at MGH. How is this different from mentoring? How do the departments and how do the residents view this innovation?
Well, it's hard to do it justice in just a moment, but it's different from mentoring in that it's based on positive psychology principles, and it's not so much thinking about how to reach your life goals and the long trajectory of career development, but more based on the current situation that each individual is in, how to sort of move forward and appreciate the opportunities, make the most of them, and avoid burnout. And in fact, burnout is one of the endpoints that they're looking at, and the preliminary data from the program seems to suggest that people who have residents who have participated in coaching are less likely to be burned out or less burned out than other residents. And they have more research talking about the last question as well. They are studying that going forward, and they're trying to do that at multiple institutions. But I'd be happy offline to send the reference and give more details.
Thank you, Deb. Okay, next question. While there was some inclusion of patient advocates at the Vanderbilt conference, I don't see much focus on the role patients and families can play in curricular design, teaching, and assessment. Is there any thinking about this?
That's a great question, and that did come up in several of the conferences, but we definitely need to emphasize it more. Many of the programs that were referred to that involve community outreach have involved, in fact, direct engagement with that community as to what's the type of program in the community. And I know that's going on in the WWAMI program in the Northwest, and in several other programs we heard about that. But I would say that it has not been as broadly embraced as it needs to, that not only for community outreach, but even when you're staying on your own home turf, to have the input of the patients, families, and communities that you're serving. So I would say that's an area that needs more work. I think it's part of the kind of outward-looking nature that we see as the trend for GME. One of the outward-looking features is the engagement of patients, families, and communities, not only in the direct care they're getting, but in the training of the people that will be serving them. So I think it's an area that needs more emphasis. We're seeing the beginning of it, and we need to do more of it. So ask the others. I mean, maybe Suzanne, you want to say something about the community engagement in the WWAMI programs?
Yes, thank you. This is Suzanne Allen. So definitely with our pediatric training track, there's certainly been significant community involvement in Bethel, Fairbanks, and in Anchorage in the development of those programs and how involved the residents are in the communities. One resident out in Bethel started a school clinic, which definitely was working with the community to help meet the needs of children in that area, with the community really wanting that school clinic that the resident helped to develop. The other thing I would just comment on are teaching health centers. So teaching health centers, as many of you may be aware of, started back in 2011 and really provide opportunities for residents to train in a community health setting or a community health center or a rural health clinic or tribal clinic setting. By definition, those centers have to have a board of directors that includes 51% of the board members being patients. So certainly those locations, there's plenty of buy-in from the patients who are being served by those teaching facilities. We have a number of those teaching health centers in family medicine around the WWAMI region as well.
And this is Donald. The only thing I would add is I think as we have programs like these Macy regional conferences and other discussions on GME, I think what we learned at our conference was not just wanting to hear the individual patient's voice, but opening the forum when we're discussing graduate medical education to bring in leaders from those areas, as well as city and county health officials who are very much involved with the patients in a different way for their health care. Just allowing them to be part of these conversations about how we train physicians, I think was incredibly valuable to those of us who do the training, but I think also was empowering them to become more involved as well.
Great. Thank you, Donald and Suzanne. Okay, next question. Given the increasing interest in medical education careers, including among trainees, how can current trainees and recent graduates get involved in these efforts?
Great question, and I think we have seen in a number of programs the ability to, again, define tracks, and in some places one of those tracks has been those who want to pursue careers in medical education have been allowed to use elective time or what may have been a research block of time to focus on educational research and or on actual teaching. So I think that's more common than it was in the past. We didn't actually quantify that. I can't tell you exactly how many are doing that. I think it's a very important area, and again, it's part of tailoring and individualizing education. We should be thinking of career pathways and how this valuable period of time is helping to prepare people for their careers without neglecting the fact that everybody needs to become competent in their specialty along the way. So I don't know whether others want to comment on that, on preparing careers for teachers.
Yeah. Well, George, George, this is Donald. I would add to that. It's not just getting residents involved in their medical education, but also helping empower them to transform the healthcare system. So, with one of the presentations I didn't speak about was the Choosing Wisely efforts of our residents at Vanderbilt. That presentation was given at the conference by a resident. The entire effort has been led by residents and fellows and is transforming aspects of our medical centers in ways that wasn't occurring 3 to 5 years ago. So I think we have a growing interest for residents to be involved. I think having them continue to speak up, to get involved, to approach their institutional leaders, I think there's a wonderful opportunity there.
This is Deb. We have a program that we call Centers of Expertise, which is career track opportunities across specialties. So we have one in global health, one in quality and safety, another in health policy and management, and certainly one in medical education. And it allows residents to come together after hours and meet with faculty from across all specialties to talk about topics in medical education. And we also have associated with that a small grants program for resident-initiated medical education projects that they do with a faculty mentor.
We have time for one or two more questions.
Okay. Someone asked if you could please provide some examples of programs which have been supported with state funding, and how are you able to advocate for these?
I'll make a couple of opening comments, and then I know both Don and Suzanne had examples of this in their conference. First of all, this is something that we didn't go into this series with a particular goal of trying to study this, but it came up so often that we now are talking about doing a more intensive review of what's going on. And we've been talking to some other people that we might partner with that. So it's clearly happening. It generally arises from an initiative that is state-based, that identifies an area of need, not enough primary care doctors, not enough psychiatrists, or generally not enough physicians. And so it may not be specialty specific. So it arises out of a constituency that comes forward and says we need to do something about this. And it's becoming more prevalent, even at times of tightening budgets, that the interest in states of providing more resident opportunities, because the statistics are pretty strong that while there's not 100% retention, there's greater than 50% retention, and in some places higher than that. If you did a residency in an area, you're more likely to stay. So the movement is local, and it's been very successful, and we heard many examples of it. And Don and Suzanne, do you want to speak to that from your regions?
This is Suzanne, and I'm happy to talk about this a little bit. So certainly each of the 5 WWAMI states provide state funding for graduate medical education in some way. The state of Washington is only for family medicine residency programs, even though there's more than just family medicine residency programs in the state. Alaska and Wyoming, it's only for family medicine currently, as that's the majority of the residency programs in those states. Idaho provides funding for all GME residency programs in the state currently, and I would say that's been a wonderful effort by all of the GME leaders in the state, as well as the Medical Association and Hospital Association in the state, to really work with the governor's office and the legislature to ensure that we have that funding ongoing, as well as looking at the possibility of expansion of GME with ongoing state support for that. And then finally, in the state of Montana, they've actually utilized general funds from the state and worked with their Department of Health to have Medicaid GME funding through an 1115 waiver with Medicaid. And that's been very successful for the state of Montana as far as providing increased funding for the residency programs in the state. So those are just a couple of examples of the state support within the WWAMI region.
So, and this is Donald. I think aside from many, if not most of the states in the South having some level of GME support through Medicaid, where the states are wonderfully contributing, specifically the states of Georgia and Florida, as George alluded to, realized that within their own states there was definitely a shortage, particularly of primary care fields, not just medicine, but also pediatrics, family medicine, psychiatry. And so those states earmarked considerable dollars to fund the development of new programs and new institutions, as those states, by any measure, were well underrepresented in terms of the number of physicians they were training relative to the populations within those states. I think what will remain to be seen is both of those efforts are only 2 to 3 years old. Will be whether or not the product of those programs stay in primary care fields, don't further subspecialize, and do they stay within the state. I think they've put a lot of parameters to try to encourage that, including where they've placed the programs, how they've designed the programs, how they're recruiting for the programs. But it remains to be seen. Mississippi is about to launch a similar effort, and we will see the fruits of that, I think, in the coming years.
Great. Thank you, Donald. All right.
We have time for one more question.
Okay. What specific strategies are used to integrate IPE elements into curriculum, and what challenges do you face in doing so?
That's a great question. As many of you know, the Macy Foundation has had a great interest over the last several years in interprofessional education, and I think we've made great headways at the undergraduate level, where there is, in fact, greater parallelism in the training of the professions. It's more complicated. We very much appreciate at the GME level, because that parallelism with other health professions is not as clear. We certainly applaud the development of nursing residency programs, which has been recommended initially in the Future of Nursing study and then in the follow-up study last year published by the IOM. And the VA has developed those and has some very innovative programs in its centers of excellence in primary care, where nursing residents and internal medicine residents are working side by side, co-managing panels of patients in the clinic. So we need to be creative. I think the opportunities for interprofessional education will be different in different settings, but they need to be sought out. And it sometimes will be with parallel trainees. It sometimes will be with junior staff people in the various professions. So we need a greater emphasis on it, and we need greater creativity to find the right match in the right place at the right time. But we saw enough examples to tell us that it can be done. I don't know if others want to comment on the IPE issue.
George, I would add to that one of the areas is finding common needs in terms of training. So, for example, the social determinants of health area clearly has been a reason for Florida International to do interprofessional training with nursing and public health workers as well as physicians. But it also broadens out with some of the work that's going on at Duke with Lloyd Michener and people there. It was clearly a conversation with the people from the CDC who came to our conference, and our conference seemed to talk a lot about population health and social determinants, which can be a trigger for even greater IPE efforts.
Yeah, I agree with that. So, go ahead, Deb.
Sorry, yeah, we've got another example of the same idea at the fellowship level, where we have practitioners and physicians who are focusing on being community health leaders who are in a program learning side by side. We also have very specific examples of IHP in simulation, where caregivers are coming together to work on quality and safety issues.
Yeah, I was just going to say that the content areas that lend themselves to it are quality and patient safety, and the social determinants of health, the community outreach programs, of which we heard many examples. There need to be more, but it's very heartening how many examples we heard. So I think we need to wrap up now, and I'm just so pleased with the interest in this, the excellent questions that we got. We will try to post responses to other questions that we didn't get to. And I encourage all of you to go back to home and be inspired by this innovation. Look up the report online and can request a printed copy from us if you want that, and we'll have copies to distribute for those who want to use them to stimulate innovations in their own institutions. I want to thank my 3 chairs that were with us on this call, but also thank the 3 chairs who were not here. All 6 did a spectacular job in leading the conferences and creating the environment of excitement, enthusiasm, and inclusiveness that was represented in each of the conferences. So thank you all, and we hope that we'll keep this conversation going.
All right, thank you. This concludes the webinar on the latest Macy report, Innovations in Graduate Medical Education, Aligning Residency Training with Changing Societal Needs. The video and slides will be available on our website next week. You can find the report on our website at macyfoundation.org, and you can also sign up for periodic email alerts from us. And as George mentioned, for any questions we were unable to answer during the webinar, you can follow up with us via email, and we'll post the answers on our website. Thank you for participating, and have a good day.